everyone had a good holiday weekend. I hear it was pretty quiet on campus, so that was good to hear. I want to just start out, as usual, by asking if anybody has any questions left over from last week. No questions? Okay, and also, did anybody have any trouble getting into the meeting today using the link? We just had to change the link, and I just want to make sure nobody had any difficulty. Okay. Does anyone have any questions about assignments and how the knowledge check submission is going to work? Okay, thanks for responding. It is good to know people can hear me. So it sounds like somebody had a little, if you were waiting for a little while, we do put people into a waiting room first when you get on. So that may be why you were waiting. But I just want to make sure that the link itself is working. It seems like now we have a lot of people coming in. Okay, well, as usual, just let us know if anybody does have any technical problems. And also, I just want to remind everybody that I will stay after class today. So if at any point the sound isn't great and you don't quite hear what I say, or you just have any questions about slides, I'll stay after class and you can ask me then. And of course, I have my usual office hours tomorrow as well. All right, so today we are going to start a discussion about designing research in developmental psychopathology. And I know a lot of people kind of groan when they hear about research design. It can be a little bit of maybe a drier topic than some of the other ones. But what I'm hoping you'll get out of this is an understanding of why it is so important to do research and how we can do research to ask the really interesting questions that we have in the field. And, this will also help you when you read some of the additional articles that you have in your reader to understand how you can interpret them. So we'll start out by talking about different topics in research that developmental psychopathologists might be interested in. And then we'll talk about how they go about answering those questions, what kinds of methods might be typical methods that are used, and then specific ways of designing studies to answer those questions, and we'll end with a brief discussion about ethics in research. As usual, I'm going to stop along the way, but if you have any questions, ask them out loud, or Hannah will be monitoring the chat room, and she'll either respond to you through the chat room or ask your question out loud if it's a more extensive one. So one of the very basic questions we might want to ask in the field of developmental psychopathology is what's called the epidemiology of different disorders. Epidemiology, just like in the medical field, basically refers to how disorders are distributed and how they express themselves across different populations. So we might ask questions just about the base rates. We just want to know how common disorders are. One really important question that's been coming up in the field lately is whether certain types of disorders are increasing in their base rates over time, and then, of course, why that might be. So when we think about base rates, there are two terms you need to know. Incidence refers to the rate of new cases over a particular period of time. So we might say, what is the incidence of new cases of social anxiety disorder across a 1 year period? So in the past year, how many new cases might there be in a particular population? Prevalence refers to the rate of all cases, which would refer to how many, if we look at the past year, how many people have social anxiety disorder, regardless of whether it emerged in the past year or whether they've had it for several years. So incidence is the rate of new cases, prevalence the rate of all cases. Another really important question that comes up in this field has to do with the expression of disorders across development. So what kinds of symptoms do children or adolescents of different ages show? As we'll discuss when we talk about diagnosing disorders, you can be diagnosed with a disorder but have a different set of symptoms from somebody else who's diagnosed with a disorder. There's often going to be some overlap, but maybe some different symptoms. So throughout the lecture today, I'm going to take conduct problems as an example so that we can talk about something very specific for each of these questions. So in terms of the expression of disorders, we might ask, how does the nature of conduct problems change across development? And somebody asked a question in the last lecture relevant to this. Is antisocial personality disorder in adults similar to when I talked about antisocial behavior in adolescents? And in fact, it is a continuity, as we'll talk about later in the semester, with conduct problems over time, but the exact symptoms that you might see are going to change across development. And so, yes.
There's a question, sorry. Would a person in remission for a disorder count toward the prevalence rate?
Yes, they would actually account for prevalence rates.
Thank you.
Does that answer that? Okay. So we might ask, in younger kids, if you're going to have some type of conduct problem, what might some of the types of symptoms you'd see in a 4 or 5-year-old look like? What might symptoms look like in a 7, 8-year-old or a teenager? So for example, in younger kids, we might see more tantrums and refusal to do things, and maybe some physical aggression. As kids get older, we might start to see things like cruelty to animals, maybe running away, more serious types of violence. And so the exact types of symptoms might change, even though there's some underlying problem that's similar. Another epidemiological question has to do with the course of disorders. So how likely, if you have a disorder at one point in life, are you likely to have it again? That's called recurrence. A disorder recurring means that you have an acute phase where you're diagnosed with the disorder, and then the symptoms go away, and then it comes back again. Chronicity refers to how long symptoms might occur. So rather than coming back again, these would be symptoms that just continue over a period of time. And remission refers to the question somebody just asked. If you're in remission, it means that you had a disorder at one point in time, but you no longer have it. And another type of epidemiological question we're really interested in the field is comorbidity. How often do different disorders co-occur? And this can be really important for understanding how symptoms are going to express themselves, as well as what might be the best treatment. So we'll be discussing comorbidity when we talk about specific disorders. Any questions about epidemiological research? Okay. So some of the most common questions we ask in this field have to do with the correlates, risks, and causes of disorders. So correlates are merely associations. What kinds of factors might be associated with having symptoms of a particular disorder? So for example, we might say, when children are showing higher levels of aggression, are they more likely to also be failing at school? This is just understanding what some of the other characteristics of children with this disorder might be. A risk factor, in contrast, we are assuming that it precedes a disorder, it comes first, and it increases the likelihood that a disorder will appear. So in this case, we have to show that the particular characteristic we're interested in is going to come before the onset of a disorder, and that it increases the proportion of children who develop the disorder. So for example, do children who are exposed to violence in the family or in the neighborhood, are they more likely to develop conduct disorder? So to be a risk factor, we have to show that they're exposed to violence before they show the symptoms. And we also have to show that they're more likely to show the symptoms than somebody who's not exposed to that risk factor. Now, causes are similar to risk factors in that they have to come before a disorder, but the assumption when we talk about a cause is that it actually determines whether or not a disorder happens. So a risk factor is just predictive. It's just increasing the likelihood that a disorder will occur over time. A cause is, the assumption is, it is the proximal cause of the development of the symptoms. So for example, we might ask whether having specific neuropsychological deficits actually causes children to develop conduct disorder. Now, as you might imagine, it's pretty hard in our field to actually identify causes because there are many factors that might occur before a disorder happens, or many risk factors, but we don't really know often what is precisely causing a disorder. And that has to do in part with the kinds of research designs we can use. As we'll talk about, we can't really manipulate neuropsychological deficits and say, okay, we're going to have one group of children who we make sure we create neuropsychological deficits and another group who we don't, and see which develop conduct disorder for obvious ethical reasons. So it's often hard to actually determine causes. So most of the time what we're doing in the field is looking at risk factors. We will talk about some designs where you might be able to draw some conclusions about causes. Anybody have any questions about correlates, risks, or causes? Okay. So now we get to our best friends, moderation and mediation. We've talked a little bit about these before because people have been asking questions about moderators and mediators. I guess a lot of people have heard about these. These are probably two of the concepts that create the most confusion in this class, and so I'm going to go through them carefully, but if you have any questions, please follow up because we really want you to understand the difference between moderators and mediators. So a moderator is a variable that influences the direction or strength of association between variables. So let's say we know that when children have a more irritable temperament when they're younger, they're more likely to develop conduct disorder. So what type of association is that? Children with more irritable temperament are more likely to develop conduct disorder. What would we call irritable temperament? Based on what I was just discussing.
Are you asking what type of association, or?
Actually, I'm asking, so based on the preceding slide and the type of question you might ask, in this case, if irritable temperament is more likely, children with irritable temperament are more likely to develop conduct disorder. Irritable temperament would be what?
Would it be aggression?
You're thinking of how it might express itself, and it may express itself as aggression. I'm noticing that we have some people on the chat who answered what I was thinking about, which is it's a risk factor, right? So irritable temperament is likely to predict the onset of conduct disorder. That means it's a risk factor for conduct disorder. But we might ask the question, for which kids or under what conditions does irritable temperament lead to conduct disorder? Remember we said irritable temperament increases the likelihood that conduct disorder occurs, but it doesn't necessarily mean conduct disorder will occur. So some children who have an irritable temperament when they're younger develop conduct disorder, but other children don't. So the question of moderation is, when does irritable temperament predict conduct disorder, or when is it more likely to? Right? So it might be that it's more likely to predict conduct disorder in some children than others. So for example, it might be that children who are born with this irritable temperament, they just have very negative responses to the environment. They get frustrated very easily. They may be more likely to develop conduct disorder if they experience harsh discipline. So if you have a child who gets frustrated really easily, and the parent responds by just spanking them or yelling at them or telling them not to be so negative, the parent isn't really helping them learn how to control their temperament, and they may be more likely to act out when they get older, maybe be aggressive to other people or get into other types of trouble. But if you have a child with an irritable temperament who has very calm parents who are able to help them regulate their emotions, they may be less likely to develop conduct disorder. So when we talk about moderation, we're going back to the concept we talked about in an earlier class of interactions. Irritable temperament is interacting with harsh discipline to create a risk for conduct disorder. Okay, so if we go back to the question, for whom or under what conditions does irritable temperament lead to conduct disorder, it's more likely to lead to it in children who also are exposed to harsh discipline. Okay, does that make sense to everybody? Any questions about moderation? Okay, so mediation asks a different question. Mediation is the process through which one variable leads to an outcome. So the question here is, why does exposure to violence lead to conduct disorder? So exposure to violence, as we said, we know is a risk factor for conduct disorder. When children are exposed to domestic violence, they're more likely than children not exposed to domestic violence to develop conduct disorder. But the question is why? What's going on when you're exposed to violence that might lead you to develop a conduct disorder? And when we answer that question, we're looking at a mediation process. So it may be that when children are exposed to domestic violence, they have more trouble learning how to regulate their anger. Remember, we talked about modeling, and we said that children learn through modeling their parents. So if they notice that when their parents are upset, they engage in violence toward each other, they may model that and think that that's how you deal with anger. If they're exposed to domestic violence, they may have parents who aren't able to teach them how to calmly deal with a problem when they have it. And so they may be more aroused when they're stressed. And that poor anger regulation then may make them more likely to develop a conduct disorder. Okay, so with mediation, we're looking at a process and we're trying to understand why a risk factor might lead to a disorder. Any questions about mediation or the difference between moderation and mediation?
You know, the diagram, I see under the poor anger regulation, there's like another line that's going to exposure to domestic violence.
Yes.
Disorder. So does it sometimes not mean the mediator to get to it?
That's a really good question. Why do I have this arrow going here? Well, there are a couple of reasons. So first, I just wanted you to understand that, you know, the primary relationship we've started out with is exposure to domestic violence leading to conduct disorder. And then we're trying to identify this pathway that explains that. But you are right that it's possible that poor anger regulation is not the only mediator. So some children may be exposed to domestic violence and be more likely to develop conduct disorder for other reasons. Can anybody think of another possible mediator here? What might be another reason why being exposed to domestic violence leads to conduct disorder?
Like being unable to form like proper relations with others, like wouldn't that's also be a mediator, like or social skills.
Yes, I'm not sure. I understood what you said. I'm not sure if everybody did, but that actually is a very good example of another mediator. So if you're exposed to domestic violence, you may not have the opportunity to learn strong social skills about how to negotiate and cooperate with other people, and having very poor social skills and not knowing how to interact with peers could also make you more likely to develop a conduct disorder. That's an excellent example. Okay, so those mediators are explaining why exposure to violence predicts conduct disorder.
I had a question.
Sure.
So for moderation, I know that you use the example of like when a child is more irritable, they can develop conduct disorder, but then you use the example of like someone who has irritable temperament is more likely to develop conduct disorder if they have harsh discipline. Wouldn't that be somewhat of an example of a mediation, like specifically the harsh discipline?
Well, So one thing that we'll discover is that any one variable does not necessarily have to be only a moderator and only a mediator. So you're raising a really important point, and you are absolutely right that it's possible that if you are a parent who has a child with an irritable temperament, that you start engaging in harsh discipline because of that, and then the child develops a conduct disorder. So I hope I'm not confusing people, but it is possible harsh discipline could act as a mediator. The assumption that I'm making here is that some parents come into parenting with the idea that harsh discipline is a good thing. So, like, some parents may have the attitude, no matter what their child's temperament is, they might think that you should spank a child or you should be very, very strict with children. And so let's say, for example, a parent just has a genetic predisposition themselves to have poor anger regulation that leads them to discipline their child harshly. It's possible that harsh discipline is not happening because of the child's temperament, but the parents would use harsh discipline on any child. So in the case of, this is what we were talking about with interactions, the assumption here is that irritable temperament and harsh discipline are not necessarily causally related, that some parents just may be more likely to use that type of discipline than others. Does that answer your question?
I think somewhat. I think I'm just looking for like a specific determinant that divides the two because they're just so similar.
Yeah, well, so, let's say we take, maybe my example of a moderator is too closely related. What about if you have a child who has a very irritable temperament and let's say they're exposed to a parental death, for example, something that's completely independent of their temperament. So their temperament is not causing a parental death in any way, but if they have this tendency to respond with poor regulation when they experience a stressor, they still might be more likely to develop conduct disorder. So in that case, the moderator and the risk factor are completely independent of each other. So basically the way that we test this, it's not always a conceptual distinction. It's not always that certain variables are only mediators and certain variables are only moderators. It has to do with the way that we basically test how those variables work together.
I think that example helps a lot. Thank you.
Okay. However, the death of a parent could never be a mediator. Well, I shouldn't say never, unless child caused the death of a parent, which we don't want to think about. So there's some variables that really are only going to be a moderator. But with, mediators, it can be a little more complicated. Really good question, though. Thank you for clarifying that. Okay, so another set of questions that we might ask in research in research and developmental psychopathology has to do with treatment outcome. So when we are developing certain treatments, we want to determine whether or not they work better than either doing nothing at all or than other treatments. And there are two types of treatment outcome research that are done. One tests the efficacy of treatment, and the efficacy refers to the success of treatment under well-controlled conditions. So when we're testing efficacy, we're thinking about we're conducting the treatment maybe in a lab with graduate students who are very carefully trained and supervised, and we're making sure that all of the treatment is being done in exactly the same way. And then we want to know if it's sort of done in the optimal way, does it work? Effectiveness, so what we might do to test the efficacy is we would have really consistent training. Treatment fidelity refers to making sure that everybody's following through on the treatment manual. And we also might select our clients carefully. We might say, well, let's see if this treatment works in children who only have conduct disorder and not children who have other types of disorders as well. Effectiveness refers to success in clinical practice. So if we take this treatment and we teach therapists in different clinics to do this treatment, does this treatment still work? So in the case of effectiveness, we might have therapists who all come from different backgrounds with different types of trainings. We're not going to be selective about the clients. It might we would do the treatment with any client who comes in with a conduct disorder. And we want to see, can we actually be successful when the treatment is conducted in real life kinds of settings? Now, with treatment outcome research, we're often also interested in moderators and mediators. So in terms of moderators, we might ask, under what conditions is treatment effective? So, for example, it might be, I'm sorry, did somebody have a question? No? Okay. It might be that a treatment is really effective if you're working with a child who has very strong support from the family, who helps the therapist kind of make sure the child is doing what they're supposed to be doing at home, who just provides emotional support to the child. And it might work less well if you have a family that's not supportive. In terms of mediators, remember the question is always why? Why is treatment effective? Why is it helping? And so, for example, we might see whether or not the treatment that we're doing actually improves parenting practices, which then may lead to decreases in conduct disorder symptoms. So, for example, if you're doing a parent training program where you're teaching the parent how to give the child different consequences when they're aggressive, and you see that the child is getting better, you would want to know, well, is the child getting better because the parents are being more effective at their parenting? Any questions there?
So I'm still a little bit confused about the efficacy and the effectiveness.
Okay, so efficacy is when we are looking at whether or not a treatment works under very well-controlled conditions. So when we first develop a treatment, we might want to make it kind of look at it under the most optimal conditions. So we might want to pick clients who are kind of have a very simple types of cases. Sometimes, for example, children with conduct disorder are also abusing substances, they're also depressed or anxious, and we might say, let's only include children who have conduct disorder and not some of these other issues. We might do the treatment in the lab, so that the families would come into the lab, they would have the, maybe graduate students or other interventionists who are very well trained, who get supervised, who make sure that they're always performing the treatment in the way that it's supposed to be performed. So what you could say is, well, the conditions are not really natural. It's not necessarily what things are going to look like in the real world. But first, we want to optimize the likelihood that it works. We want to make sure that the treatment itself is a good treatment. But then, obviously, we want to say, well, okay, it works under these really optimal conditions, but will it work in real life? Will it work in the everyday world where we don't always select our clients? We rarely do. Where maybe therapists all have different types of training and nobody's actually watching to make sure that they're doing exactly what they're supposed to be doing. And so those would be questions of effectiveness. Can the treatment work in a naturalistic setting?
Okay, got it. Thank you.
Okay. I see a question in the chat. For mediators, is the treatment trying to improve the conduct disorder symptoms, or is the treatment meant to improve parenting? That's a really good question. So in this case, the ultimate goal is likely to be to decrease the conduct disorder symptoms, right? That's kind of the outcome that you're hoping the treatment will have, to lead children to not show the symptoms. But you often want to know why it's working. Why is it decreasing the symptoms? Because let's say that you have one treatment where you're teaching parents very carefully and you're spending hours and hours and hours teaching the parents how to deal with the children's outbursts, temper tantrums, for example. And you think that that's going to help the child to show fewer symptoms. But if in fact the symptoms go away and parents are not actually showing better parenting, then we have to rethink things and think, well, what is the treatment doing that's helping? So we talk about, for example, non-specific treatment effects. Maybe the treatment is just working because the kids have somebody supportive and calming in their lives, and it really has nothing to do with improvements in parenting. And it's important to understand why our treatment is working so we know how to develop our treatments. We'll talk about treatment outcome toward the end of the semester, but some treatments are really, really extensive where we're working with parents and kids and teachers, and they're really costly. And if only one of those aspects of our treatment is working, then that would be helpful to know because we might then not need the other parts. Does that make sense?
I have a question too. Can I ask it?
Yes, absolutely.
So I see that for like the moderator, it would be like strong family support, but then for the mediator, the why would be the strong family support. So I'm kind of confused with the difference between that.
So with the moderator question, it may be that the treatment doesn't even involve parents. Let's say you're doing cognitive behavioral therapy with the child, and the child comes in once a week and the parents drop them off and they go through various types of exercises, sessions that teach them how to change the way they think about situations and maybe teaches them some anger regulation skills. In that case, we wouldn't expect that the treatment is going to increase family support, right? So again, with moderators, the assumption is that the independent variable is not necessarily causing a change in the moderator. So in this case, the treatment is not causing a change in the family support. It's just that you happen to have a supportive family, and that family is helping to, like, let's say the therapist gives the child homework to do where they're supposed to monitor themselves and engage in some of the things they learn in the session. If you have a supportive family, they might be more likely to make sure the child actually does that homework. But the treatment itself is not assumed to be creating that family support because the families aren't really involved at all in the treatment. In the mediator question, I'm suggesting that the treatment might be a parent training program where the treatment is directly trying to target parenting. Does that make sense?
Yes, thank you.
So again, with moderators, the independent variable and moderator are not assumed to be related to each other. With mediators, the assumption is that the independent variable is influencing the mediator. Okay, so does anybody want to try generating a research question that you think would be interesting? And you can say, which type of research question it is. You don't have to pick conduct problems. Like you can pick any problem and just come up with what do you think would be an interesting research question for that particular disorder.
I just have a quick question.
Yes.
So, like, in terms of like asking a question, then I guess could we say like, would the epidemiology of like anxiety disorders be different in like low SES neighborhoods versus like higher?
Absolutely. That would be a really good example of a question we're interested in terms of epidemiology. Are the rates of disorders different in different populations? For people who've probably most of you have heard, for example, that the rates of COVID seem to be much higher in minority populations. That's an example of an epidemiological question that is really important for us to understand because we need to understand why, and obviously we also need to think about treatment efforts. And in fact, I was just listening to the news and they were saying, for example, that because we've realized that the rates are much higher in minority populations in the vaccine trials that they're doing now. They're really trying to recruit more minorities because they need to figure out, is the vaccine working in the people who are at highest risk? So you can see how an epidemiological question can lead to really important implications for treatment. Yeah, that's a really good one. Anybody else want to try to come up with a question? Who wants to be brave and think of a question related to moderation or mediation? Nobody brave today. Okay, how about who can think of a risk factor question that you might ask?
I have one.
Okay.
So I mean, we could do like something like how are there higher rates of ADHD when children spend time in their early years like with a lot of screen time?
Yeah, that's actually a really interesting question. People have been very interested in screen time and difficulties children might have, whether it's ADHD or aggression. Later on, we'll talk about that in our aggression lecture. So that's a really good example of a risk factor question. Okay, we've got one on the chat. To what extent does parental support buffer against depression in LGBT children? That's a really good example of, so what Jacob is doing is kind of the flip side of a risk factor is a protective factor. And those are definitely questions that we're very interested in the field. We want to know not just what makes children, oh, I'm sorry. And actually I should say, you're actually giving a moderator question. Sorry, I have to read this more carefully. So that's even more interesting. The risk factor would be a child who is identified as LGBT, and the protective factor would be the moderator. So does the relationship between being identified as LGBT and depression in children differ for children with high versus low parental support? It's a really good example of a moderation question. So the question, the next question in the chat, how does physical punishment by caregivers toward children differ among cultures? So that would be an epidemiological question. It wouldn't quite be related to psychopathology. But I'm going to take your question one step further because this is a super interesting question that actually people have done research on. Because physical punishment does seem to differ among cultures, people have asked a moderation question: is the relationship between physical punishment and negative outcomes such as depression different in different cultures? So for example, if you have a parent in the US who physically disciplines their child, is their child, are children more or less likely to become depressed than if parents in another culture use physical discipline? So that would be actually an example of moderation by culture. Anyone else?
I'm not super sure if I have the whole mediator moderator thing now, but for mediators, would a question like why does bullying in someone's childhood lead to anxiety disorders or social anxiety be a mediator type?
That would be a great mediator question, and can you think, or can anyone think of a possible mediator? So the question, why might bullying in childhood lead to some type of anxiety disorder, is a mediation question, and then we need to think about what kind of mediator would we look at? Why do we think it might lead to more anxiety?
Could it be the comorbidity of a person already diagnosed with depression?
So you're thinking that bullying might lead to depression, which would then lead to anxiety? I'm not sure exactly what you're...
Possibly, and those who experience like depression have a high comorbidity of also being diagnosed with anxiety?
Yeah, it's possible. So the one thing about mediation is that you're assuming a timeline here, a temporal sequence. You're assuming that the mediator happens before the outcome, right? So you would be, I think your example works if you think that bullying might lead children to become depressed, and being depressed then might lead children to being more anxious. But often the anxiety and depression kind of co-occur, and we don't really know which came first, so that might be a little bit harder to find that relationship. Can anybody think of another reason why bullying might lead to anxiety?
Could it lead to like low self-esteem?
Okay, so we have two people.
Sorry, I will go first. Sorry. Could it lead to like low self-esteem, which would then lead to anxiety?
Exactly, that would be a really good example of, and people have in fact looked at that very mediator. Does being bullied a lot in childhood decrease your self-esteem, which then makes you more anxious around peers later on? Okay, and what about the other person?
Hi, I was going to say around the same thing of they're expect to be bullied more, or I believe it's in social psychology, it's called like spotlight theory, where you believe you're being watched all the time.
Yeah, that's a really interesting idea. I haven't seen that social psychology idea applied here, but I think it definitely could be. It would certainly make you more socially anxious if you feel like you're kind of a target and everybody's paying attention to you. Then you're going to be anxious when you're around other people. Really, really good ideas. And I see a few more on the chat group. Bullying prevents a child from creating strong peer relationships, which could create anxiety. That's a really good example. And increased stress could lead to the development of anxiety. Yeah, so these are all really, I'm glad you guys are tackling mediation and moderation, because the best way to learn them is to come up with your own examples. I'm going to move on so we can make sure I don't have to go too fast through the end of the lecture. So how do we go about answering these questions? We talked a little bit about different types of risk factors we're going to be interested in, and we're going to probably measure them in different ways. So one way we often get information, probably one of the most common, is just reporting. It might be self-reports by children, it might be parent reports, teacher reports, but we might have them fill out different questionnaires, or we might interview them one-on-one to get information. We're often interested in psychophysiological and neurobiological risk factors. So we might use methods such as seeing what people's heart rate is in different situations, or blood pressure, EEG, which tells us about brainwave patterns. We might measure hormones as a risk factor. We talked about a couple of studies last class where people were using neuroimaging to identify different functional differences in the brain. And we might do observations where instead of just asking people what they're usually like, we actually watch them. So we might go out into their worlds. We might like do family observations by going to their home, or we might bring them into the lab where we actually set up a scenario where we want to observe them. The strange situation that we saw a tape from last week, or the study where they were showing the spider to the little girl, that would be an example of structured types of observations where we set up a situation and watch how they respond to it. So we're going to talk about, kind of all those different types of methods in the various research that we talk about this semester. So when you're measuring a variable, when you're trying to either ask questions or do interviews or observe, etc., what would you want to know about your measures in order to trust the findings from a study? What do you think is important to know about the way that you're measuring what you're interested in?
One thing that you would want to make sure is that your measurements are reliable. So, like, if you think of somebody taking a test or a survey, that they would get the same scores.
Exactly. So you want to know the measures are reliable. So the kind of reliability that you're talking about is retest reliability, or consistency over time. So if you get a score one day and then you measure the same thing 2 weeks later, for most things you would expect the score to be pretty similar. So you want to know that you can see high reliability over time. Anything else? Looks like we have go ahead.
Sorry. Like it was mentioned in the chat, but because like psychological studies are kind of hard to define measurements for like non-quantifiable variables and factors, like we mentioned validity, like how that is defined and assessed for things that are hard to measure. Like in like a couple lectures before, you discussed something about like social contentment in children, and like how would you measure that? So like that defines kind of a conflict or a factor where it would be harder to potentially trust research findings with factors that are so hard to measure in our daily lives.
Yeah, that's a really good way of framing validity, that sometimes we just don't know if we're measuring what we think we're measuring, because there are some of our concepts are a little bit elusive and we come up with measures, but we don't really know, are we getting at what we think we're getting at? So that would definitely be an example of validity. And then somebody else mentioned being able to apply the measure or the finding in the lab to the real world, which is another type of validity. So let's break down. We're going to go through all of these different types of measurement evaluation. So one thing we need to do is make sure that we standardize our measures. We need to know, is everybody who's using the measure using it in the same way? Because sometimes we might have a measure, like for example, if we're coding information, let's say we do observations and then we're coding them, and everybody uses a different coding system, then we really don't know if we can compare across one study to another. So we typically come up with some norms. Another example is with questionnaires. If we want to determine on a questionnaire what score might be a cutoff that's meaningful. So for example, we give a social anxiety measure and we want to know which kids probably have severe levels of social anxiety. Well, every study might have a different sample, and so we don't really know for overall what should be a good cutoff to determine if somebody has severe levels of social anxiety. So we often standardize measures in large groups of children, and we create those types of norms in a large population that we then can apply to our smaller sample. We talked about reliability. So one example, reliability is basically the consistency of the measures. We can talk about consistency over time, which somebody gave an example of test retest reliability. We can also talk about consistency between different people. So if you're developing a coding system and you have one person do all the coding, you have no idea if that person is really accurate in the way that they're coding. So usually what we would do is have at least two people do coding, and we'd make sure that they can come to an agreement and they can code independently and have similar perceptions of what they're coding. So those would both be examples of how consistent our measures are. And then validity has to do with the accuracy of the measure. Are we measuring what we think we're measuring? Can we distinguish what we're measuring from other types of constructs? So face validity refers to basically, it's a pretty simple kind of validity. Let's look, for example, at the items on a questionnaire and see if they seem to be measuring what we want to measure. Now, this seems like an obvious one. Well, if you develop a questionnaire to measure depression, of course your items are going to measure depression. But funnily enough, sometimes you look at a measure that's called, it has a name of a certain construct, and you think, these items don't actually seem to be measuring that construct. And so face validity is the first step, but it actually is not always obvious that people have face validity even. Convergent validity refers to whether or not different measures of the same construct are strongly correlated. So if I wanted to develop what I think is a good measure of depression, I'm going to need to show that it strongly correlates with other measures of depression that are already out there. At the same time, I have to show discriminant validity, which is showing that my measure is different from measures of other constructs. So somebody mentioned earlier, depression and anxiety are very strongly correlated, and sometimes measures of the two really can't distinguish them. So with discriminant validity, people have been trying to find aspects of depression that are separate from anxiety and aspects of anxiety that are separate from depression to try to discriminate the two of them. Okay, so convergent validity, you want your measure of a certain construct to correlate with another measure of that construct. Discriminant validity, you want your measure of one construct to not correlate very strongly with a measure of a different construct. And criterion validity often refers, it's somewhat related to the type of validity somebody mentioned about can you predict or apply your construct to the real world. So usually we would pick a criterion that we think, well, this is kind of the gold standard for this, a gold standard for measuring this construct. So in development of psychopathology, for example, as we'll talk about in the next session, we often think of the DSM, the Diagnostic and Statistical Manual, as our gold standard for distinguishing different types of disorders. And we'll talk about all the problems with that, because now there are a lot of questions about whether it should be the gold standard. But in the past, we've said, well, if I develop a measure of depression, I want to make sure that it can predict diagnoses on the DSM, because diagnoses on the DSM is kind of my gold standard. That would be an example of criterion validity. Another example might be if I want to develop a measure of how aggressive children are, then I might go out to the playground and observe them with other kids. And maybe if I do that over several, a day, a week, over several weeks, I'm going to capture how aggressive they actually are in real life. And then I would want to know whether my self-report measure of aggression predicts how aggressive they are in real life. Okay, any questions about standardization, reliability, or validity? Okay, I'm going to move on, but if any questions come up, then just let me know later. So when we're designing a study, we also have to figure out what sample to select. We're going to go to a particular setting or source to recruit our children. And so we have to think very carefully about how we recruit our children and what the implications are for what we can conclude from the findings. So we always have to be thinking about, are there threats or biases when we select our sample? What kinds of biases might occur in my findings based on who's participating in my study? So what are some possible threats? Who can think of possible threats to having an unbiased sample?
Like if it's not representative, or I guess just too homogenized.
Yeah, so if we have a homogeneous sample that's too similar, all the kids are coming from, somebody on the chat group says the SES, socioeconomic status of children. So let's say I advertise in a school newsletter, and all the parents who sign up for the study are kind of upper middle class parents. And so the children are from a very specific demographic group. Then what I find might be true for those children, but it is a biased sample, might not be true for other children. Anything else? Okay, so to give some other examples that often come up in the field of developmental psychopathology, one question we often have is whether we are recruiting children with a certain level of severity of a disorder. So, for example, if we recruit our sample from an inpatient psychiatric unit, obviously the children there have very severe levels of the disorder, and there are enough issues that the child has been hospitalized. So if I find something in that particular group, we don't really know that it's going to apply to groups of children who have less severe symptoms. We've discussed comorbidity a lot. So if I have a group of the degree of comorbidity in the sample will influence my findings. So if I'm interested in risk factors for depression, those risk factors may look very different if I have children who are depressed only versus children who are depressed and have conduct disorders. So I have to consider that aspect of my sample. Somebody else mentioned cultural differences. So absolutely, if we have a sample from one culture, we don't know for sure that our findings would apply to another culture. Okay, so all really important things to think about, and we have to think about what sample is most appropriate for the question we want to ask. We also have to evaluate, so one type of validity we need to think about is the internal validity of our findings. So this refers to the extent to which a particular variable, which is a variable that we're interested in studying, rather than some other variable accounts for my results. And this can be a little bit complicated, so we can go through some examples. So let's say that you are interested in whether or not a treatment seems to be having a positive effect. And let's say that somebody's in the treatment over a period of months and they seem to get better. We would like to assume that our treatment is basically what caused them to get better, but it's possible that as the children just get a little bit older and more mature, they're getting better over time. And so that's why we would always need to compare our treatment to a control group where they're not getting the treatment or they're getting some other treatment, so that we can rule out those types of maturation effects. Another example would be testing effects. We know that when we ask people the same questions multiple times, we actually see changes in their answers. And most commonly what we see is people reporting fewer symptoms over time. So we see this quite a bit in my research on depression, where we will do measures of depression over a period of several months. And it seems as though in general, the rates of depression go down over time. And even when we look over several years, so children are getting older and we know that there are actually increases in depression with age, we sometimes see them going down over time because of these testing effects. So we have to think about whether or not the variable that we're interested in is causing the findings or some other variable.
Does that finding, could that be considered like a form of Hawthorne effect?
Tell me about what the Hawthorne effect is.
Like the phenomenon where the participants act differently because they know they're being watched, or they know that.
Yes, that could be part of it. So one thing we always worry about, which would probably be an example of a Hawthorne effect, maybe I'm loosely speaking, we do interviews often to interview people about different experiences, including psychopathology. And so when we do the interviews, if they give us positive responses, we have a lot of follow-up questions and the interviews are very long. And it is possible that the participants over time think, I don't want to do this really long interview. I might just say no to some of these questions. With observations, the Hawthorne effect comes in a lot. May not be just over time, but even if you're observing children in the lab or anybody in the lab, they know they're being watched and they may act very differently. And so it might be children who are less aware of being watched might be more likely to act aggressively in the lab than they, but maybe the other children be equally likely to act aggressively on the playground. So yeah, that would be a good example of internal validity problems.
Okay, thank you.
External validity refers to how much findings can be generalized to the outside world. And so as we mentioned, depending on your sample that you're drawing from, you can only generalize back to certain populations. And so we often want to, even if we start out with a more select sample, we would then want to replicate our findings in order to show that it replicates in other samples as well. So threats to external validity might be, well, okay, you know what, I take it back. I guess I did use reactivity as an example of external validity, because if they're acting differently in the lab and in the outside world, that would be more an example of external validity. So the idea that somebody is aware that you're watching them, and they might act differently in the lab than they would in real life would actually be an example of external validity. So I apologize for that. And then we also might think about the setting. So when we were talking about efficacy versus effectiveness of treatment, if we have a treatment in a very controlled setting in the lab, as I described, we don't really know whether or not that would be generalized to natural settings like clinics. So comparing efficacy versus effectiveness would be an example of seeing whether or not there's external validity for our treatment. Does that make sense? What's the difference between criterion validity and external validity? Criterion validity isn't necessarily always about generalizability, but it can be. So one example I gave for criterion validity was, do self-reports on my measure of aggression predict how children act on the playground? So in that case, that's an example of criterion validity, but it's also an example of external validity. The other example that I gave for criterion validity, does my self-report measure of depression predict diagnoses of depression on the DSM? That would not necessarily be an example of external validity because it's not about generalizing my findings. Does that distinction make sense, Nicole? Okay, so what I want to move on now is to talk about different types of research strategies. So how do we go about designing a study to ask a question of interest? So one example would be a single case experimental design. In this type of study, we're actually only studying one individual. And I would say this type of study is fairly rare, but it is sometimes used in treatment outcome research most commonly. And so a reversal design or an ABAB design is where we're interested in whether or not an intervention works. And so we basically measure a certain behavior of interest. Maybe we measure how aggressive children are. That would be the A. The B would be that we then institute a certain type of intervention and we see what happens to that level of aggression. Then we take away the treatment and we measure aggression again and we see does the aggression then change now that they're not in treatment anymore? And then we would reinstitute the treatment and see whether or not the behavior changes again. So I'm going to go back to the rest of this slide, but I'm going to show you an example of an ABAB design. So if you have a child who has difficulty at school because they keep jumping out of their seat, and you want to institute an intervention to try to decrease the likelihood that they jump out of their seat. Maybe the teacher gives them a reward every half hour if they don't get out of their seat. So the baseline, the A, you're measuring how frequently they get out of their seat, and then you institute this intervention and you see that the number of times they get out of their seat decreases. But then you take away the intervention. They don't get a reward anymore, and they get out of their seat more frequently again, and then you reinstitute the intervention and down it goes again. You could probably conclude that this intervention is being pretty effective for this particular child. And you can also use a multiple baseline design where you might have several different behaviors you're interested in, and you start out intervening with one of them and just keep the others natural and see what happens, and you would assume that the behavior that you're intervening with would decrease, but the behaviors that you're not intervening with would stay the same, and then you might institute an intervention for a second behavior and see if that one changes. So this would just be an example of a more complicated type of design. Now, what's nice about these designs, especially compared to just observing a single kid and seeing what happens, is you have this systematic control where you have no intervention, intervention, no intervention, intervention. So you can really compare, the child is basically serving as their own control. But because it's a single case design where you just have one child, obviously it's going to be very hard to generalize whether or not this treatment would work for other children. So we tend more often to use group-based designs. And there are many different types of group-based designs. A correlational design would be where we're just looking at things that might go together. So remember, we said sometimes a research question might just be, does something in particular correlate with the disorder we're interested in? So we might just look at natural covariation. We might measure how often children are watching TV and how aggressive they are, and figure out if children who watch more TV or engage in more social media are more aggressive. The problem is that we don't know what's causing what. We don't know if children who are more aggressive just like to watch TV more, or if watching TV causes them to be aggressive, or if there's some other factor involved here, like maybe they have very little parent supervision and that's why they're watching more TV and why they're more aggressive. So a correlational design can tell us whether things go together, but we don't necessarily know why they go together. A cross-sectional design is where we're interested in differences between children of different ages. So remember, we said one of the epidemiological questions we might be interested in is whether different symptoms of conduct disorder are expressed at different ages. So we might take a sample of 7-year-olds and a sample of 10-year-olds and measure symptoms of conduct disorder and see whether or not the 10-year-olds and 7-year-olds show different symptoms. Now, advantage of this design is that we talked about testing effects, and if you keep asking somebody something over and over, they may change how they respond. When you're comparing children of different ages, you don't have any testing effects to worry about, and you don't have to worry about whether some of the children drop out of your study over time. But disadvantages are that you don't know if there's something different about that sample of 7-year-olds and 10-year-olds. So, for example, let's say you go to a particular school and you get some 7-year-olds and some 10-year-olds, but something has happened at that school that the 10-year-olds experienced and the 7-year-olds didn't experience. That might be why they're different instead of the fact that they're different ages. So that would be an example of a cohort effect. And also, we can't see what happens to the same children over time. We don't know whether 7-year-olds who show certain types of symptoms of conduct disorder become 10-year-olds who show other symptoms. It could just be that there's something different about these two ages. So to deal with those issues, we often will use group-based designs where we compare children with different types of disorders or different types of experiences, and we just look at naturally occurring differences. So in a non-experimental design, we are not assigning children to groups. So this isn't the type of thing where you come into the lab and they're doing an experiment and they put you in one group or another. In a non-experimental design, we're comparing naturally occurring groups such as children who have conduct disorder and children who don't have conduct disorder. And for example, we might be interested in whether children with conduct disorder show higher levels of school failure. So again, when we have this non-experimental design where we're just looking at naturally occurring differences, this is very much like a correlational design in that we don't know what the direction of effect is. It could be that when children start failing at school, then they kind of feel like they don't fit in and they start acting out. Or it could be that children who have conduct disorder aren't doing their homework or aren't paying attention to the teacher, and that's why they're failing in school. So we do sometimes use experimental designs. And with an experimental design, if you've done any experiments in the psychology department yourself, you know that you are usually being assigned to a certain group. You typically don't know that there are two groups and you're being assigned to one of them, but you are, the experimenter is randomly assigning people to be in a certain group, and then looking at whether or not the people in the different groups differ on what they're interested in. So if we go back to our example about whether or not watching more TV makes kids more aggressive, in an experimental design, we might actually take two groups of kids and tell the parents, okay, I want your child to watch X amount of TV per week. And the other group, they might say, I don't want your child to watch any TV during the period of the experiment. And in this case, when we are deciding who's in which group, we can have a stronger assumption about whether or not TV watching is causing aggression. So if the group that is assigned to watch lots of TV ends up showing more aggression than the group assigned to not watch any TV, then we might be able to conclude that the TV watching is actually causing the aggression. This type of design is great because you're really controlling your independent variable. You're making sure that with random assignment, the kids should be, the kids who are watching TV and not watching TV should be similar in other ways because you're just determining who goes in which group. But the problem is that in the field of developmental psychopathology, many of the risk factors we're interested in just would not be ethical to assign people to. Right? We can't assign people to whether they're exposed to domestic violence or whether they're exposed to bullying. So what we do is what's called a quasi-experimental design. In a quasi-experimental design, we don't assign people to groups. We study naturally occurring groups. So we might, for example, study children who've been abused by their parents and children who have not been abused by their parents. And we might compare those groups to see whether the abused children show higher levels of conduct disorder. Now, if we find the abused children do show higher levels of conduct disorder, because we haven't assigned them to that group, we can't be sure that it's the abuse itself that's causing the conduct disorder, right? We have the third variable problem. Well, children who are abused are often from lower SES classes. They often have parents who have very high levels of stress in their life. They might have different genetic characteristics. And so when we do a quasi-experimental design, we compare these naturally occurring groups, but then we might match them on other characteristics that we think could be relevant to the outcome we're interested in. So a very common one, for example, is socioeconomic status. If we want to conclude that it's abuse and not being from a lower socioeconomic status class that causes conduct disorder, we can match the kids who are abused and not abused on SES. And we can say, well, let's make sure that we have either both groups only have kids from low SES classes, or maybe both groups have equal numbers of kids from lower SES and higher SES classes. But that way we can conclude that it's not SES that's causing the differences. So that helps us rule out some other variables, but you can't control for all the possible differences, of course, between the groups. So it gets us a little closer at causal assumptions, but we still can't be sure. Does anyone have any questions about these designs so far? No questions? Okay. So another kind of design we might use is an analog design. I'm sorry, I see somebody say the same question as Nicole. So that was a question about criterion and external validity that I answered. So I'm going to ask you to just, if you still have that question at the end of the lecture, why don't you ask it then? In an analog design, what we're doing is creating really well-controlled conditions in order to see whether or not we see differences between different groups. And we do this in a way that's ethical. So for example, if we want to know whether or not abusive parents are maybe less disturbed or less concerned or more concerned about a child misbehaving. So one hypothesis about why children or why parents might abuse their children is that abusive parents are just really tuned into child misbehavior, and it's really distressing to them. So we might actually create an analog of this situation in the lab rather than studying what happens when their child misbehaves, because there's a big history there and we don't know exactly what's gone on in the past. We might show them a videotape of a child misbehaving, and perhaps we measure their heart rate and we see whether or not they become more aroused when they watch a child misbehaving. And in this case, we're creating the same condition for every parent. So we can claim that if they're showing higher heart rate and they're getting more aroused when a child they've never met before misbehaves, then it's likely because of differences in the way they respond to misbehavior in general. Another example of the analog design is the strange situation that I showed you. We often use analog designs where we're interested in, for example, how children deal with a stressor with another peer. We might create a situation in the lab where we have a child interacting with another peer and we systematically introduce the same stressor to all the children and we see how they react. So in an analog design, we can study something often that's not a high frequency event. So for example, we're interested in peer conflict, and if you just went onto the playground and watched for a while, you might not see peer conflict. So you can study a low frequency event in very controlled conditions. The problem is that when you create an analog situation in the lab, you don't know for sure that it's going to apply to everyday life. So you might have some limitations to the external validity of your design. Any questions about quasi-experimental or analog designs?